Good evening, everyone. It's my great pleasure to welcome you all to this webinar. It's the first webinar we are conducting since we took over as the new managing committee. On behalf of the managing committee, ISC, I would like to extend warm greeting to our eminent speakers, Dr. Swati Daftari ma'am, Dr. Prajna Sawant ma'am, who will be sharing their valuable insights and recent advances in the field of NORA. We are honored to have you with us today, madam. And a warm welcome to our respected guest, Dr. Naveen Malhotra sir, President ISA National, and Dr. Sheetal Dalal ma'am, Honorary Secretary SAMS. I also welcome Dr. Rochna Bakshi, who is the moderator for the session, and all the senior anesthesiologists who have joined today, and our dear residents. Now I request Dr. Naveen Malhotra sir to kindly share your thoughts with us. Dr. Naveen Malhotra sir, he has problem in joining, I think. Dr. Sheetal Dalal, you can say a few words to.
Okay, respected Dr. Naveen Malhotra sir, President Alvina D'Souza ma'am, then the Honorary Secretary Anjana Vajekar, today's eminent faculty Dr. Swati madam and Dr. Padna Sawant madam, and all delegates. A warm greetings from the Society of Anesthesiologists Maharashtra State. So I congratulate first both President and Secretary to be installed as the President and Secretary and taking over, and very good initiative by team of Navi Mumbai to start this academic activity. Best of luck, madam. And I request you to make more and more FPF members, then more CPR activities from your side. So best of luck for all your vendors in future. Thank you, ma'am.
Thank you. Thank you so much, ma'am, for encouraging us. Thank you so much. Sir, Dr. Naveen Malhotra, sir, can you share your thoughts with us? Welcome, sir.
Am I audible now?
Yes, sir, you are audible.
Yes, sir.
But I think the network is not good. Hello, sir. Hello. Hello, sir. So we are not able to hear you. Hello, sir. Hello. Sir, it's okay. No problem. I think it's difficult to get the network.
Maybe sir is on airport.
Yeah, sir is inside the flight. It's okay, sir.
Inside the flight.
Yeah, he's on his way to Indore. Okay, sir.
Yep.
We'll continue. Thank you for joining, sir. Now I request our Honorary Secretary, ISA Navi Mumbai, Dr. Anjana Vajekar, to conduct the academic program further. Over to you, Dr. Anjana.
Very good evening to all our members. It is my pleasure to introduce the moderator for the day, Dr. Rochna Bakshi Madam. She was also our past president, past secretary, ISA Navi Mumbai. She is a professor in anesthesiology with 27 years of clinical experience and 19 years of teaching experience. She has previously worked in Apollo Group of Hospitals and currently affiliated with D.Y. Patil Medical College, Navi Mumbai. Over to you, madam.
Thank you, Anjana. Good evening, one and all. Before we begin, a humble request to all attendees to please mute themselves before the speakers begin, and kindly type your doubts or questions in the chat box as they'll be taken up by the faculty at the end of the session. Now, non-operating room anesthesia is challenging because it requires maintaining the same standard of safety as a traditional OR while working in environments that are often not designed for anesthesia. Now, these remote locations, it may be the MRI suite, the endoscopy unit, the cath lab, each one has its own unique hurdles. And closed claims data definitely shows NORA-related deaths are due to substandard anesthesia care, compromised monitoring, respiratory events, inadequate oxygenation, etc. So today, to sail through these situations smoothly, we have two stalwarts of our country who will highlight on this topic in adults as well as pediatric population. It is my proud privilege to introduce our first speaker, Dr. Swati Daftari, a popular and respected name in the field of anesthesiology. She is Senior Consultant and Advisor, Department of Anesthesia and Pain Management, Sir H.N. Reliance Foundation Hospital and Research Center, Mumbai. She is visiting professor at Stanford University School of Medicine in the Division of Pediatric Anesthesia. With more than 35 years of experience, she has made remarkable contributions to patient care and medical practice. Now, throughout her distinguished career, she has also mentored and guided the next generation of medical professionals. She has delivered more than 75 guest lectures, authored chapters in books, and has many publications to her credit. I extend a warm welcome to Madam Daftari to share her valuable insights. Welcome, ma'am.
Thank you, Roshna, for your nice introduction. And good evening, friends. Special thanks to ISA Navi Mumbai for this invitation. So we're going to talk about NORA essentials for safe practice in adult patients. So what is NORA? NORA is nothing other than non-operating room anesthesia, which refers to all anesthetic procedures performed outside a traditional operating room. And as you all must be knowing, it's a rapidly growing field in healthcare with expanding case volume and complexity. And it seems that it may account for up to 50% of all anesthetics within the next decade. NORA sites have a greater proportion of high-risk patients not fit for traditional operative procedures or who are very high risk for traditional operative procedures. Performed in a high volume and fast paced environment by usually a single anesthesia provider in a workspace not optimized for anesthesia care. And that is why you can understand why we are discussing NORA today. So it can include all possible procedures, but not limited to radiology, interventional radiology, or neurology, cardiology, pulmonology, gastroenterology, and others. You may think that the list is incomplete, but the way NORA is expanding, yes, it might be incomplete in next couple of months also. So what should be our goal as an anesthesiologist for NORA? It is to provide immobility, analgesia, amnesia, and comfort without compromising safety. And we must treat each patient as unique and not abide by routine. You cannot say this is standard sedation for so and so's case. So, what are the challenges to provide safe care in NORA settings? So that you can see the list is endless. Remote location, far from pharmacy, supplies and health, noisy environment, limited workspace, limited patient access during procedures, inadequate lighting, minimum temperature regulation, electrical and or magnetic interference, old, possibly unfamiliar equipments, lack of scavenging, lack of skilled anesthesia support staff, inadequate power supply, and as you look at the safety of the patient, we need to look at our own safety, which is radiation safety. And you must know that this team may be unfamiliar with anesthesia, the procedural team, whereas anesthesia team may be unfamiliar with the procedure. So we should consider this as a team event and have to have good discussion before we start the procedure. More cases come after normal working hours, and there are increased percentage of emergency procedures. So this is a non-validated scale where a relative risk level by NORA venue has been put up in a graphical manner. And it says that based on airway complexity, hemodynamic risk, shared airway, and limited access, cath lab and interventional radiology, as well as bronchoscopy and IBUS because of shared airway, form the highest risk profile. Whereas the next which comes is ERCP and EUS, pediatric MRI, and then as we go up, the risk profile goes on decreasing. Upper GI endoscopy, adult MRI, colonoscopy, and radiation therapy. So if the risk profile increases with the venue, we have to be ready with the location where we are going to give anesthesia. So this is where the mnemonic SOAP-ME helps you for the facility checklist. S standing for suction, working suction, and space, that is adequate patient access. Oxygen, pipe supply, backup emergency cylinder, functional flow meters, devices to allow its delivery, that is the bag valve mask, and now you have, of course, high flow nasal oxygen. A for airway and allocated area for recovery with staff, oxygen, and monitors. P stands for pharmacy, where drugs for sedation, life support, and antagonist. Power, you need adequate sockets, UPS for critical monitors or major monitors like defibrillator, and personnel. Whereas M stands for monitors, relevant monitors with size and age appropriate accessories. And E stands for special equipments like defibrillator or difficult airway equipments. So if your facility cannot demonstrate these elements reliably, if possible, you should move this procedure to OT or hybrid. And as you know that you cannot anesthetize what you cannot rescue. And hence the facility checklist becomes very important. Coming to personnel, you must have experienced anesthesia staff as well as non-anesthesia staff, which would help you in carrying out pre-anesthesia assessment, managing airway, CPR, and use of anesthesia and resuscitation drugs. Whereas non-anesthesia staff would help you in providing equipments and drugs during maybe cardiopulmonary emergencies. If they are familiar with anesthetic procedures, they can help you out with putting up the monitors, helping in taking IV line, and even helping during intubation. And they would be a big help during post-procedure anesthesia care and resuscitation. You all know the sedation has been divided into minimal sedation or anxiolysis, moderate sedation, earlier known as conscious sedation, which is a misnomer. Next would be deep sedation, and the last would be general anesthesia. But they are not so clearly demarcated. When you start sedation, you tend to go or drift deeper, or patient can become lighter than intended, as the boundary is clinically critical and blurred. So you cannot say that your patient is going to remain always in moderate sedation. If you are not careful, your patient may become deep or may become light. And hence it is called the continuum of sedation. And as you go deeper, there is an increased risk for adverse events and there is increased need for intervention. So what are the high-risk adult patients for NORA? Elderly patients, somebody like more than 70 years, ASA physical status 3 and 4, anticipated difficult airway or limited rescue access, cases of physiological fragility like severe OSA, obesity, pulmonary hypertension, advanced COPD or interstitial lung disease, significant heart failure, unstable arrhythmias, severe valvular diseases, raised intracranial pressure, sepsis or shock. All these patients make a group in high-risk patients. And procedures like shared airway, need for absolute immobility, long duration, high aspiration risk, major bleeding risk, or radiation constraints which limit your proximity to the patient can also make patients high risk. And hence, if the procedure in NORA is going to be so high risk with issues of its own, the pre-assessment becomes very important. So you should have taken a detailed clinical history and examination of starvation, past history of any surgery or anesthesia and sedation, any history of being on antiplatelet drugs, or especially in a female of young age group, you must ask history of pregnancy. These are some of the histories which are important. In fact, the pre-assessment has to be as good as any patient undergoing surgery in the OT. The pre-procedure investigation should be individualized based on patient conditions and comorbidities. Also, depending on the patient's medications and procedure invasiveness. You can't have a full battery of investigations for all patients. In fact, if you are practicing endoscopy anesthesia, you would have realized by now that the GI endoscopists or endoscopists call their patients fasting to their OPD, saying that suppose if I think something is required for you, then we will do it at the same sitting. So it is very likely that you may not get any investigations. But yes, if certain investigations are required because of the patient's comorbidity, you must get them done for patient safety. So in general, one must focus on airway, cardiorespiratory reserve, aspiration risk, and hemostasis or anticoagulation whenever it is relevant. Please optimize comorbidities. If a patient is asthmatic and when you auscultate him, you can hear wheeze, please give nebulization and then check again whether the patient has improved or not. Plan post-procedure destination early, whether patient is fit enough to go home, to PACU, or requires high dependency unit or ICU. Fasting, because you want to give sedation, or maybe you will start with monitored anesthesia care and you may have to supplement it with a sedation, is very important. So in adults, you have clear liquids, including carbohydrate containing fluids, acceptable until 2 hours before procedure in healthy adults. But if your patient is a case of CKD, CLD, or maybe a very obese patient, then for solids, you have to be extra careful. The general rule of 6 hours may not be good enough because all these patients have gastropathy. Also, in today's time, you have to remember with the easy availability of GLP-1 agonist, many of your obese patients might be on weekly injections. So your history has to include that because that is going to delay their gastric emptying a lot further. So you must, depending on the patient's condition and comorbidities, decide on the fasting guidelines. Also, there are sometimes people have asked me if the patient has come from home for OPD and the endoscopist feels that he requires a colonoscopy. So the preparation will start then. So when do you do colonoscopy? Colonoscopy should be done after about 3 hours of finishing the prep fluid. Before that, although it may be clear, the viscosity is different and hence it may give you trouble. Also, if the patient has been prepared for colonoscopy and if the NORA list gets delayed, it can result in prolonged fasting, dehydration, and electrolyte issues. So you must start IV for these patients. And if there is a delay, you must reconfirm the starving status before taking the patient into the procedure. Consent is very important in NORA, and you must realize that it has to be a separate anesthesia consent, and the procedure consent cannot cover or does not cover anesthesia. Also, consent for one procedure does not authorize a materially different procedure. For example, if the patient is for check gastroscopy, and if the endoscopist finds varix and he wants to band them or inject glue, it is best not to allow to go ahead with this without confirming with the relatives. And in fact, we've had a episode where the patient, when he got up, got irritated and said, was it a life saving? Why did you not wait for me to get up and ask me, and then should have gone ahead with the banding or glue injection? So that is what it is. Also, when you mention consent, you must mention the alternative, because as I told you, it is a continuum of sedation. Even if you've started with MAC or a awake patient, you may end up giving sedation, which may progress to GA. You may have to intubate. You have to give advice about the recovery and discharge limitations. One must document when we talk of pre-assessment, ASA, airway class, fasting status, what are your monitoring plans, and what are the drugs that you are planning to use for the patient. Monitoring standards, non-negotiable or the minimum monitoring that a NORA needs is continuous ECG, non-invasive blood pressure monitor every 5 minutes, continuous SpO2 monitoring, and temperature monitoring in longer cases, especially when you are doing a neuroradiology, where you have coiling or you may have flow, the saying a diverter being used, then you will need temperature monitoring also. When do you add capnography? Whenever you are going to increase the depth of sedation or deeper sedation is required, when you think that the response to verbal contact may be lost. And I must tell you, when you give supplemental oxygen to these patients, what happens that SpO2 lags by almost 3 minutes, and it may not show for 3 minutes that there is a hypoventilation going on. So that is where capnography becomes essential. When you have special environment consideration or special venues like MRI suite, you must have monitors which are MRI compatible, and no ferromagnetic equipment should be taken past the line. And also, you must designate a safe area for patient rescue. In cath lab and interventional radiology, for our safety, you must wear PPE in the form of lead apron, thyroid shield, glasses for safe monitoring of the patient. Also, you should see to it that the patient is also taken care of. If suppose there is a radiation of the head going on, then maybe you can cover the pelvic area with a your lead apron. In endoscopy, it is shared airway environment. You have to have aspiration vigilance, and lateral position with a backup is preferred for upper GI. Airway strategy and anesthetic technique. What do you do? So what are the airway principles in NORA? So NORA airway problems, if there is restricted access, shared airway, non-supine position as in ERCP, and your help is distant, it is far away, then you have to be extra careful. So you use least invasive airway that still provides reliability for procedure needs. You must be ready to escalate early, and planned rescue is 100 times better than heroic rescue. Pre-declare rescue trigger with the proceduralist and include it in pre-listing briefing. So I remember a case which I did recently. Patient of CKD who was quite obese, was on BiPAP, was for percute nephrostomy in prone position. So, of course, it was going to be a monitored anesthesia care, and the radiologist wanted to do bilateral percute nephrostomy. I told him that you start with the first one. I will see how it goes. And if I'm not happy, I may not let you do the part 2 or the second side, which he was very upset. No, madam, if we don't do it, the patient will run away. I said, patient will run away only if the patient is safe. So this you have to put it down. You have to explain it before it starts. And fortunately, he really put it in 3 minutes each. And patient was in a prone position with a BiPAP continuously on. Also, you must have difficult airway equipments physically present in the suite. You can't call it from theater once there is a problem. Okay. So what is the technique selection framework? Sedation or monitored anesthesia care for short, minimally painful procedures in a cooperative patient, easy rescue, but avoid sedation creep. Now, what I mean by sedation creep, suppose you are doing a OGD scopy and you are doing a scopy, you've given propofol, and otherwise everything is good, but patient starts coughing. So if you take it as that the patient is light and you add further propofol, you are unnecessarily going to deepen the sedation and patient may stop breathing. You have to think why the patient is coughing. Okay. Patient is coughing because of the presence of the scope. There is a regurg that has happened, and because the patient is in moderate sedation, the coughing reflex is still intact. So you don't need to give further propofol, but you need to do oropharyngeal suction. And you'll realize that once you do the suction, the patient stops coughing. So if by mistake you have thought of giving extra propofol, then what you are creating is sedation creep, unintended deepening of here, of course, it is not unintended. You thought that the patient was light. General anesthesia is usually used for cases where there is essential is to keep the patient immobile, as in neuroradiology, or you are sharing or controlling airway, as in cases of IBUS, or you are doing a POEM procedure, or maybe you are doing a cystogastrostomy, where when they puncture the pseudopancreatic cyst, the liquid that comes out with a gush will be aspirated by the patient. High aspiration risk and complex procedures, long and complex procedures. TIVA is preferred in MRI when scavenging is unreliable or inhalational delivery is impractical. Regional and field blocks are usually used in interventional radiology, vascular work, endovascular laser therapy, pain procedures, dental extractions, or other dental work. So you must integrate anticoagulation assessment and sedation rescue plan in these cases. These are the drugs that are commonly used, and you are all aware of this. I don't have to go into the detail of this. So what are the common, let's see some of the common adult NORA procedures and what are the recommended approaches and monitoring. So upper GI endoscopy can be done in MAC. In fact, some of the patients who have fear of sedation and anesthesia would say that, no, I don't want anything. So, but most of them would ask for sedation. So MAC or propofol sedation, your minimum monitoring should have ECG, NIBP, SpO2 and capnography done in lateral position with a backup, but there is an aspiration of risk. Colonoscopy, same, but because a sedation may, especially if it's a sigmoidoscopy, the sedation depth may not be so much. So you can decide on capnography and you have prolonged fasting or bowel prep issues. ERCP, EUS, most of us do it in moderate to deep sedation, but if the operator is not comfortable or is on a learning curve, it is best to give general endotracheal anesthesia. But I'm telling you, moderate to deep sedation works beautifully if your operator is confident and you are confident. And occasionally they may ask you to turn the patient prone if they are not able to perform it in lateral with backup. MRI handles. Now, so many patients talk of claustrophobia and all. You can talk to them, make them understand. Then you may be able to do it in MAC with some additional music and all. Otherwise, TIVA becomes best, and you should have MRI compatible monitors. Interventional radiology, like embolization, ablation, complex drains, like TIPS and all. GA or deep sedation, again, monitors are standard. Long procedures, pain surges may have hemodynamic variability. Cath lab is either monitored anesthesia care, moderate sedation, or in complex cases, it may be GA also. So if it is a complex case, obviously you will be required to put a art line, and you have to think about radiation safety, long duration, dose of heparin, which has to be reversed sometimes. Bronchoscopy and IBUS, you are sharing an airway, there may be a hypoxemia risk. So there are some people who would say bronchoscopy, they are okay with topicalization of airway and monitor anesthesia care, but IBUS would require either moderate to deep sedation or general anesthesia. Continuing with the procedures, radiation therapy, brachytherapy, these are repeat sessions. You need rapid recovery, and hence short-acting MAC or TIVA or even general anesthesia. CT guided biopsy or drains, local anesthesia plus minimal to moderate sedation. Hypoventilation can happen in prone position if you have given deep sedation, and then you have limited access and radiation hazard that you have to handle. Structural heart, like tower and complex ablations, GA or deep sedation with readiness for hemodynamic collapse, or you can use hybrid care model. You have to be aware of rapid hemodynamic shifts that can happen with long duration. Dental procedures, good sedation with MAC or local anesthesia. Sometimes patients who require a prolonged procedure may be safer with general anesthesia or deep sedation. And you have to remember about airway obstruction, bleeding, aspiration, and one should have immediate rescue capability. In IVF procedures, embryo transfer usually done under MAC, but ovum pickup, you would require moderate to deep sedation or general anesthesia. But here, in these cases, you have to remember that patient may have hyperstimulation syndrome, or also you cannot allow any delays and patient requires complete immobility. In electroconvulsive therapy, TIVA is the best. And again, here you have repeated sessions, rapid recovery needed, and you can have drug interactions with antidepressants and antipsychotics. So in NORA, if you have given moderate to deep sedation and you don't have capnography or not using capnography, you have not realized that there is a over-sedation drift. You cannot access your patient easily, and you have not recognized airway obstruction. You are going to land up with unmonitored hypoventilation and delayed rescue. And the truth is that an unmonitored respiratory event in a dark room inevitably becomes a cardiac arrest before anyone notices it. So conclusion from FDA and Anesthesia Patient Safety Foundation is that all sedatives and narcotics have caused problems even in recommended doses. All areas using sedation have reported adverse events. Respiratory depression and obstruction are the most frequent causes of adverse events, and they are because of multiple drugs, drug errors, overdosage, inadequate evaluation, monitor, and also depends on practitioner skills. And if in that scenario, if you are trying for premature discharge, it is the most common problem. So what are the post-sedation complications that you can see? Can be pain, procedural pain. For example, the patient has undergone ERCP, the pancreatic duct has been handled. Patient, when he wakes up, is going to complain of bad backache, nausea, vomiting. So you should think of procedural pain in advance and maintain the anesthesia. So like if you're doing POEM, patient is going to have a lot of pain because the myotomy has been done. But if you are doing endoscopic submucous dissection, as in cases of certain masses in the GI tract, then it is not going to be painful after the procedure. Agitation is because of etiologic pain, as I told you, hypoxia, hypercarbia, full bladder after long procedure, paradoxical reactions, and emergency reactions if you have used a higher dose of ketamine or something like that. Delayed awakening can be prolonged drug action, hypoxia, hypercarbia, and hypovolemia. Nausea, vomiting, mainly because of your agents that you have used or premature oral feeds. Serious events are again because of pain or hypovolemia, which will give rise to tachycardia, or vagal stimulation, opioids, and hypoxia, which will give rise to bradycardia. Hypoxia can also be because of laryngospasm, airway obstruction, over-sedation, or aspiration. So if you are doing NORA, you must be prepared to tackle the emergency that can happen, because NORA is time critical and access limited. We saw that. So if you have, just to prevent these complications or to treat them in good time, you can have location-specific laminated algorithms which may have something like what to do when you get into airway obstruction or apnea, means how do you escalate the pathway, or if there is an aspiration and regurgitation, or if you get into cardiovascular collapse or anaphylaxis because of your contrast, or in case of MRI emergency, patient removal protocol should be established to MRI safe zone. Also, similarly, when you do sedation, you must use pharmacology in such a way so as to avoid synergy traps. You know that benzodiazepine and opioid combination may cause unpredictable respiratory depression. So, in poor risk patients, in elderly patients, titrate them slowly. Elderly sick patients are more sensitive to sedation. Reduce the dose, give small aliquots at longer intervals. And as per Anesthesia Patient Safety Foundation data, more than 50% of NORA-related claims involving deaths were judged preventable. Also, when you are transporting and handing over the patient to a recovery area, you must have a transport monitor and know the name of the person who's receiving the patient, give them a structured handover, and the patient must be monitored until recovery criteria are met. Documentation in NORA is most important because it is your defense. A clinical decision not written is a clinical decision not made. And hence, please document informed consent, pre-anesthesia check, date and time and duration of procedure, intra-procedure monitoring, the essential monitoring at every 5 minutes, and something like level of sedation and level of pain every 15 minutes, what drugs you have used in what dosages, complications, if any, happen, immediate post-procedure patient status, recovery area monitoring, and discharge status and instructions to the patient relative. So these are very important to document. Safe discharge after NORA can happen if the procedure was of sufficiently low risk, not requiring additional monitoring. Symptoms like pain, lightheadedness, and nausea are not there or are well controlled. Vital signs are stable and the modified Aldred score is more than or equal to 9. Mental status and physical function have returned to a point where the patient can take care of himself with minimal or no assistance. A reliable person should be accompanying the patient who can provide support and supervision and should be at home for at least few hours with the patient. Clear written discharge instructions with contact number, and one should find out means of transport to home. So I distinctly remember a patient of IVF where the couple, when I asked them at the end of the procedure, how are they planning to go? They told me they had come on a two-wheeler. So obviously I had to keep them little longer because I could not have allowed them to go on a two-wheeler to a distant suburb. She would have dozed off and the gentleman would not have known whether she is there at the, as a pillion person or not. So that is very important. And also remember, if you've given a muscle relaxant and reversal agent, patient should stay for minimum of 2 hours and be monitored after the last administration of reversal agent. If you want to make NORA more safe, actually at the same time, there is another interesting webinar which is going on just now, which is on this basically incident reporting and auditing. So if you want to make NORA safe and you want to improve functioning of NORA, there are 5 metrics which need measurement. One, unplanned airway intervention rates of maybe oropharyngeal, nasopharyngeal airway, supraglottic airway, or intubation. Hypoxemia episodes, SpO2 less than 90% for more than 60 seconds. Unplanned hospital admission after NORA, where normally the patient should have gone home. Delayed discharge from recovery, took more than 120 minutes or 2 hours for the patient to wake up. And what is the checklist compliance rate before, during, and post procedure? You can have people who are practicing outside in freelance practice may say that, madam, I'm not getting capnography where I'm working. So do I do NORA or no? Then you have to have your own lateral modifications. Like if you don't have capnography for NORA, I think at least if your respiratory rate is coming from your ECG leads, then it tells you what is the respiratory rate of the patient. And from the waveform, you can make out whether the patient is breathing shallow, the rate is low, or patient has stopped breathing. So you have to decide. And in places where they ask you that what do you need for NORA, then this is your standard requirement that you can put forward. Let's see what is new in NORA. High flow nasal oxygen is a newer entity relatively in NORA. As it is warm and humidified, it is very comfortable for the patient, washes out nasopharyngeal dead space, and because of its PEEP effect, it decreases work of breathing, enhances oxygenation, and also does not allow buildup of end-tidal carbon dioxide. It can work as an alternative to NIV or non-invasive ventilation, and you have a big range. You can start at lower flow rate, and as the sedation becomes more deeper, you can increase the flow rate. And you can give almost at highest flow rate, you can give almost FiO2 of 100%. And it gives you longer apnea time. Remifentanil is available with us, which is ultra-shock acting opioid with very rapid onset and reliably short offset because of ester hydrolysis. So loading dose of 1 microgram per kg followed by infusion of 0.1 to 0.2 microgram per kg per minute, modified for patient pattern. So this would be a good drug to use for maybe ESDs or maybe gastrocystostomies, or where you are doing a neuroradiology. It gives you very stable hemodynamics during the procedure. And as these procedures are not associated with pain which cannot be tackled by something as simple as paracetamol, they are, this drug is good for such cases. Remimazolam is a newer drug which is being tried abroad for basically endoscopy. We still don't have it available, but it's basically a combination of short-acting benzodiazepine for IV administration, and it has both ester hydrolysis of remifentanil, and it also retains GABA agonist property of midazolam, which is safe in renal and hepatic impairment, and the GABA agonist property can be reversed with clomazanil. The only problem with it is it has to be given in a slow bolus as 5 milligram, and the next bolus, if required, can be given of 2.5 milligram over 15 seconds, but after only 2 minutes have elapsed of the first dose. So to summarize, if you are doing NORA, please have safety in place. And this is a nice one-page checklist. Pre-procedure, patient identity, procedure, site, allergies, and all the red flags should be confirmed. ASA status, airway class, fasting status, and consent to be documented. IV access confirmed. Oxygen and suction should be functional and monitors connected. Intra-procedure, timeout with sedation, stroke airway plan, and rescue trigger points are communicated to the proceduralist. Baseline vitals should be documented, and NIBP cycle should be set at every 5 minutes. And sedatives obviously should be titrated slowly. One person should be designated through sedation and monitoring and should not be doing multitasking. Post-procedure, structured handover to recovery staff and see to it that the monitoring continues until baseline is achieved. Discharge criteria should be documented. Escort and written instructions should be provided. Adverse events, unplanned interventions, and transport arrangements have to be documented. And last but not the least, to summarize the NORA as such, as you know, it's an anesthesia care delivered outside the conventional operation theater. The core principle, and this is the most important part of the lecture, the NORA must meet the same clinical standards as the operating room, same monitoring, same rescue capability, and same documentation. One must be ready with the environment where you are working. Patient selection should be accordingly. Monitoring must have all airway rescue gadgets, and governance becomes very important. And to promote safe NORA practice, you should have tiered resource planning, site-specific SOPs, NORA protocols, and NORA registry. Because when you run audit cycles and review critical incidents, it is learning for one and all. And credentialing must be there on for BLS, ACLS, competency in airway rescue, and simulation and drill should be carried out repeatedly. That's all. Thank you so much.
Thank you so much, ma'am, for that systematic, elaborate, and step-by-step approach to NORA in adults. We have almost 2 or 3 questions in the chat box. So should we take them now or at the end?
At the end, madam.
Okay. Okay. So we move on to our next question. It is an honor to introduce our next speaker, Dr. Pragya Sawant, madam, a distinguished senior pediatric anesthesiologist of our country. Dr. Sawant is the head of department at B.J. Wadia Children's Hospital and also the course director of Pediatric Anesthesia Fellowship Program. She is also faculty with the Indian Dental Association, imparting training on dental sedation in pediatric patients. She is founder and past president of Indian Association of Pediatric Anesthesiology, also founder member of the All India Difficult Airway Association. Under her leadership and clinical expertise, she has organized several workshops and lecture series portraying her deep commitment to teach and mentor young doctors, shaping the future of pediatric anesthesiology. Madam has several orations and awards and publications to her credit. I welcome you, ma'am, to enlighten us with your expertise and knowledge.
Thanks. Am I audible?
Yes.
Hello. Am I
Ma'am,
audible?
you're audible.
Hello. You can hear me?
Yes,
Yes,
ma'am.
ma'am.
Okay. So thanks, Rochana, for my kind introduction. First, at the outset, I would like to thank you me for such a very important topic. And also, I congratulate you, Alvina and Manjana, for having the office bearer of New Mumbai.
Thank you, ma'am.
Actually, really very good topic and very interesting. Is my screen visible?
Yes, ma'am.
Yes, ma'am.
Good evening, everyone. And actually, Swati has made my presentation much in a NORA setup, except emphasize for this pediatric patients. Okay. So I give a greeting from Vadia Children's Hospital, which is an exclusive hospital, all of you know, and we do offer a fellowship and observership, and we do a lot of NORAs in a pediatric setup because we have all the imaging suits. Well, when you say a NORA, okay, you think that a beautiful girl. Okay, the name itself suggests a beautiful girl. But when you think, this picture, it has another picture of an old lady. Okay, so this NORA is also like this. It looks very beautiful from the outside, and as you go inside, all the complications when you see becomes a quite disappointing or very challenging. So it represents a growing field in the medicine. So as a result, anesthesia providers will need to enhance their families, resources, personals, and environment outside the operating room. So I think this thing, in NORA is quite difficult. Not only difficult because of the age and because of their anatomy, physiology, and the way they represents their diseases. Okay, so why sedate the pure anesthesia? The children, so this parental satisfaction, because the parents, when they see crying the child, they also quite, they are stressed. Decreases the stress of both the patients and the and decreases the stress of the anesthesiologist also when the child is comfortable. A post-maladaptive behavior is reduced by appropriate sedations. Diagnostic quality of image suffers with the inadequate sedation. Actually, this is very important. If you want a very good diagnostic image, the child has to be really very calm and quiet. Because if the child keeps crying, it is just pipeline to do. So even the radiological suits or say CT, MRI or anywhere, the people have to just wait for the child to stop crying and you do the imaging. So I think all of you know this picture, and all of you must have seen this movie, and this is like exactly every time you miss your heartbeat, what is happening to this kid, and the same thing happens in children when they outside the operating room. Okay. The same problems we also faced when the child is,
Madam, can I interrupt in between? We can't hear you, madam. Class. We can't hear you, madam, properly.
So
Madam, voice is getting cut in between.
In the children or say anesthesia in the children. So it has been,
Pragna madam.
This is a close claim data.
Madam, your voice is getting cut, ma'am.
Case and all. Yes, I have added myself. Hello?
Madam, your voice is getting cut.
Audibility is getting affected.
Pragna ma'am. Pragna ma'am, your voice is getting cut in between. Hello?
Can you hear me now? Hello.
Now it's clear.
Hello, can you hear me now?
Yes, ma'am. We can hear you now.
And we can hear, but
Yeah.
मध्ये खूप crack होतोय आवाज, खूपच crack.
Yeah.
We
In
cannot
between, there was disturbance little bit.
Yeah, there is a lot of disturbance.
Now it's clear.
Okay. Okay. It's clear. Okay. So when for these remote places, this mortality, respiratory, these events can be preventable with a better monitoring.
Ma'am, we are
Look
not
at
able
this.
to. Ma'am, we are not able to see your slides. You have to maybe start from the beginning.
Now?
No, ma'am.
Hello?
No, ma'am, we are not able to see.
I'm able to hear you clearly, actually.
Yeah, no, we are able to hear you. We are not able to see the slides now.
Okay. What is the problem?
You can close and start sharing again.
Okay. Now?
No, we can't see the slide. We can hear you now, but we can't see the slide.
Okay. Okay.
Now we can see.
No, yes, ma'am. Now we can see the first slide.
I'll go ahead. Sorry for the disturbance.
No, ma'am.
No, it's okay.
Yes,
Okay,
ma'am.
I was on this slide.
Yeah.
So I think this is, remote locations. Yeah. In the remote locations, all these problems are much more, than compared to the operating room. That is why we always worry. Okay. Now, already, I think Swati has told about why NORA is challenging, because the sicker patients and they come for the diagnostic. Actually, they are not optimized. We do not know what they are suffering. They're noisy and inadequate, lighting and the environment, limited workspace. See, all these problems are there. Definitely, we do have these problems, but how do we overcome these problems? So let us see how we can do the overcome first. Okay. So workplace is at remote place, and whenever actually a senior person usually ascends to junior to these remote locations, we have to see to it that a person who is going there is well versed with the vascular access, or say difficult airway, or maybe managing the all the emergencies. So usually, if the junior person at the remote places is sent, sometimes what happens, the help is quite very far away. The cell phones are not working. By the time they call you, okay, the code blue may not be the building, maybe some separate building is there. So by the time you reach there, it is the adequate time is not there, because safety of the patient is important, and child does not give you much time. Once they start deteriorating, they go into bradycardia, and the anesthesiologists go into tachycardia. That happens quite frequently. Well, minimum temperature regulation because of this coldness, because it is mandatory that AC is full on because of this imaging. This thing, without that doesn't work. So the most of the children, specifically neonates, they go into the hypothermia. So this is a major problem. If the duration of, specifically in MRI, the duration is longer, the child becomes a hypothermic. So you have to see to it that the child remains a warm. Electric and the magnetic interference, definitely we cannot do about that. Radiation hazards, I will talk about. The help is further away. What you should do? So if the help is further away, when whether you are in an institute or whether you are in a private practice, see to it that if in case of problem, or in case of any mishap, how you will get the help. So that beforehand you can think over. So usually in our institute, we see to it that whenever the MRI list is, which are the problem cases are there. So that time one more person goes and helps the persons, okay, the person who's there in the MRI, so that person is never alone. Or if the difficult airway or difficult vascular access, then the senior has been called beforehand, so that you do not land up in the problem. Okay. Now, how about the cell phone reception? See to it, the intercoms are working functionally, or how to, initiate the code blue. That hospital system has to decide in case of any problems, how to initiate these emergency services. That's very important. It is always a lonely walk through a dangerous path. But I think definitely we can overcome all these problems. We cannot just keep on talking, okay, these are the problems. As such, we have to work and, overcome these problems. Well, I don't have to talk about the equipments, because the all outdated and the insufficient the equipments are usually sent to the CCT and the MRI. That usually happens in the institute. Okay, but you have to ensure. And sometimes what happens, the location and the equipments are also, you are never taken into the, usually administrative people, they never take anesthesiologists into consideration when they are building the CT and the MRI. So that's a fact actually. So ideally they should be included to form the theater, how the anesthesia workstation is there, or what the standard equipments are there. Usually now SOPs are there, and it is a mandatory that all the equipment, standard equipments and working equipment should be there. Lack of skill supportive staff, I don't have to tell about, every time the staff changes. So if the neonate goes in the problem, and if you want to have a laryngoscope, or the adult laryngoscope is handed over to you, or the 6 number tube is handed over to you, so usually they do not have that training that suppose if the child goes into problem, how to help the anesthesiologist, even the proceduralist even. So I think that effective communication, team building, clear expectations from everyone. Everybody is, work has to be assigned. In case of problem, what? And the biggest is the training. All the imaging people who are, working in these NORA sets up, they have to undergo training for the CLS, the way how to, and have to see to it that, all the equipments are in a functioning this. Even the anesthesiologist has to check before, starting the case. Now they have a new complex, invasive and the risky procedures. As we go on the modern these things, the newer and the newer procedures will come. Sometimes they stent or sometimes they do, which we are not very familiar. So when you are thinking or going for the new procedure, which you do not know, jointly you communicate with that procedure, and the pre-operative time what has to be there. You jointly think over what means procedure they are going to do, whether in supine position, how much time there. So if the time duration is long, you can plan your anesthesia. If the time duration is short, that person is proceduralist, is very experienced one, the time duration can be short. This is a very important thing. Well, about the patients, these patients are not an adult patient. These patients are quite smaller, sicker with the comorbids. They are outpatients sometimes, because we have never seen them. They are on the day of the procedures only we see them, and they have sometimes very complex anomalies. Specifically like a neonates, infants, and the older children. Adolescents have their own set of problems, or even they may have a difficult airway, they may have a difficult vascular access, syndromes may present, hypothermia and the hypoglycemia and the anxiety, specifically in a small children, they do have adolescent, they do have these things. Like children who are having the difficult airway, it is quite difficult to get the oxygenation. And if you are very lucky to have this kind of patients also, you can do not one, a double dhamaka, if the twins you get it. So it's very difficult to challenge, anesthetize both the kids, simultaneously, and you have to take a lot of care. Well, now in a procedural management patient, so what do? You have procedure assessment. I think Swati has already talked about perfectly about think about their comorbidities, ASS history, lab test if they have not done, ability to patient, their cooperate, you have to see their allergies. Consent we have already talked about. I think the consent is basically the parental consent is there for the and the high risk consent in case if the patients are undergoing the interventional procedures, the high risk consent is required. I will talk definitely about the fasting terrace, which is very important. Positioning, what position specifically, like a prone position or lateral position, where you are going to have a problem, that also you think over. Well, vascular access is a half life. You don't think that, you just give an intramuscular and the CT is done. Never do that. You have to have one, at least some vascular access, even though it is a 24 number, because anything can go wrong. Well, when in cases of children, at least reserve one bed in step down or ICU. Usually in our hospital, one bed is always reserved for the cases for the CT, MRI, or anywhere in the NORA procedures like gastro. So if they deteriorate, we have to make sure that they are admitted. Specifically like that anything, whether in the MRI or whether in a GI suit, because these patients are quite sick patients are. So see to it that one bed is always available in case if you face any trouble. Now, Nilpal Olal, what happens usually when you have a long list where logistics go haywire, because when sometimes the previous child has not come out, taking time, 2-3 MRI or 2-3 settings are there, 3-second scans, third scan because the child is moving. The next child is keeping fasting. Okay. So usually, because of the other reasons are the booking rules, they are overbook, or say emergent or urgent cases they come, or the overlapping of the cases come. Actually, the problems lot of causes a problem in a small children, because specifically like in a children's hospital when all the children are there. In other setup, in private setup, you can at least make a way to patients and do the child, but that never happens because you're a long list and all the children are fasting. So create a NORA scheduling rules. Okay, so you have to give us some gap, whosoever because that even becomes a taxing for the anesthesiologist to see that the children are important. Specifically, like in a summer sea water, say NPO rules, NPO guidelines have changed. Okay, now the IAPA, all over the world, even the 1 hour before the water, you can definitely give. Okay, water has a no problem. At least they have some solace. Now, what are the sedations? Like you have a minimal, moderate, this is already been talked, general anesthesia, proper general anesthesia with the consideration of the patient comfort, procedures, requirement, and safety with the unsecure airway has to be dealt with. This is also, so as you go on a moderate to deeper sedations, losing of loss of reflexes, maintaining the airway and the impaired response can cause hypoventilation and the cardiorespiratory stenosis. Okay. Well, this is a ASA continuum sedation. It is the same thing. It is a very nice paper, but it is horrific of when the safety guidelines are disregarded. I think you have to, go or do a safety guidelines. So what are the commonly used drugs? Commonly used drugs are these: midas, ketamine, dex, fent, propofol, inhalational, and now the newer drugs, as Swati said, that the remifentanil, which is not available, but remifentanil, if it is available, you can use it. Well, you can use it in a various combinations like oxygen nitrous, CO. We can give MAC, ketamine, midazolam. It is, I think, everybody's choice is there, but you have to have a good combination so that both the analgesia and the sedations are provided. So a few tricks of the trades are which I have given you, that not necessarily that you should give it in a non-invasive procedures, you just give analgesic doses. Invasive procedures, you give anesthetic doses. Okay, I think the in a NORA setup, opioid, it is better to avoid, because then the child has to be monitored, post-operatively. Those who are the OPD patients, like I said, if the patients are coming from the outside, you schedule them. Usually we schedule them in such a way that the small children are taken in the morning. Cooperative children, or the suppose either older children, they are scheduled in the evening. Okay, suppose even, and the indoor patients are still further in the evening. Suppose even if they have a problem, they are already in the indoor setup. So we see to it that before 5 o'clock, all the OPD patients, they have their food and they go away with a proper recovery. Well, this is again doses we have talked about. You can give the smaller doses or say sedative doses rather than analgesic doses you can give. Well, pre-medication, I think this does not have a much role about the pre-medication in the these suite because these are the all short procedures. We want that the child is to be should be awake at the end of the surgery. Usually, what happens when you give a pre-medications, the children keep sleeping. Okay, because you have given the larger dose because of the they are not metabolized very fast if the child is very sick, so it becomes quite a problem. So in previous days when I think 10 15 years how the team changes, you see mother would just slap the child. That was quite bad. The mother would just slap it, just go inside and go get your MRI done. That's the way. But these things cannot be done now. So I think pre-medication preferably I would avoid thinking that the patient has to be even if at all you have to give, if the child is very uncooperative, midazolam is 0.5 milligram and the ketamine oral or nasal you can give, then they work better. But if you have given the pre-medication, see to it that the child is completely out before you discharge. Well, pedicloryl and the melatonin, they are not the anesthetics pre-medication. Personally, we don't prefer them because pedicloryl is very unpredictable and sometimes causes arrhythmia. There is a delayed recovery, and sometimes it so happens that the pediatricians, they give the pediclorin and then they tell you okay now the child is not very cooperative, please sedate him. So it is our duty that now when you give a pedicloryl, then you give a midazolam, then this all these synergistic the child sleeps, there is at least 4-5 hours the child is sleeping. Okay, so then the child also goes into hypoglycemia. So I think if any one sedative is given, be sure that the next sedative you give it in a lesser dose, and be sure that the child is fully out before, because then the readmissions are required. You cannot send this child out. The child has to be admitted till he recovers and has oral foods. Well, melatonin, I think again, some centers they are giving, we don't give melatonin. I do not have much experience about the melatonin. Again, these combinations in the lower doses, they are absolutely quite good. This improves airway preservation, decreases vomiting, so no need of, and decreases the need of opioid use when applicable. So fewer boluses doses maintains the sedation, and the higher patient and the physician satisfaction score is present. So it's quite good. IM versus IV ketamine. I think it is a possibly adverse respiratory event with the IM. Okay, higher the rates of emesis with the IM ketamine and the longer recovery period with the IM ketamine. So personally, I do not like to give this IM unless the child is very uncooperative. You can give it. So whenever possible, use IV ketamine. Okay. Again, the pharmacokinetics, you should see the repeated administration before the peak effect of the previous dose is reached. That is called as a dose stacking, and the synergism when the combination of the drug increases serious side effects, especially benzodiazepines and the opioids. What are the methods to give? There are various methods. Whatever the methods you have, whatever comfortable you are, whatever equipments you have for the IV, definitely you can use it. We used to, when syringe pump were not there, we used to put drug in the 100 ml normal saline, and that was our syringe pump, and you just keep on adjusting the doses. So that was a crude method, but now the good methods are there. Monitoring, there's already this is discussed, what things should be there, and this is mandatory, absolutely must. Well, when the child is post-operatively, the recovery has to be there. In most of the centers, the recovery is not there. If the recovery is not there, see to it that in the emergency ward you make one bed available. Usually when the child is out, you can see the child in the mother's lap outside the MRI. I say that is not operatively till the child is, or if the child is very So what should the anesthetic care patient standard is easier said than done. Okay, so for the NORA destinations, here the psychiatric suit I'm not talking, because in the smaller children we usually do not give the ECTs. So these are in the adolescent age group, usually we do it. How about the city? So in a city, the procedures are quite, a CT scan usually takes a shorter, less than a 5 minutes, or within the 10 minutes, the CTs are over. Very quick, the patient and the personal radiation safety issues are the major concern, and exposure dose rate is inversely related to the square of the distance. So it is far away you should be, because the CT guided. CT is quite easy, but there is CT guided biopsies are sometimes quite difficult, especially like a mediastinal biopsy or the renal biopsy or the prone position. That is you have to be really very careful about in these patients. So here, usually what we have done is, whatever we have the extra machine, anesthesia machine, we have put it in the CT. So if any difficult vascular access, we definitely induce with a CO, and then we switch over to TIVA. So that can be, so either you use a supraglottic airway devices if difficult airway is there. If the prone position, definitely we use a ET tube if the patients are very obese or OSA patients are there. Okay. These are, I can just skip this, okay. So in the MRI scanning, it is obviously very high scan and restriction of the staff, needed specialist skill for the medical and the technical staff, and MRI to have anesthesia, this compatibility. So previously, when we used to do MRI, I have done many MRI when the MRI compatibility machines were not there, but we used to, keep the one anesthesia machine just outside the MRI suite. Just outside the MRI suite, and we used to see, okay, that the monitor we used to be there, and we used to see, suppose if the child is desaturating, or if we requires a CPR, the child has to be immediately brought out and the CPR given immediately outside the MRI, so that you have to you are having an entire your crash cart, your anesthesia machine, everything, so that the time is not wasted. Nowadays everything you get it. I think all these problems of the MRI, they have already been talked about, and we know what happens in the MRI, specifically noisy and the crampy, and this is well, nowadays the MRI, previously they were like you are entering into a tunnel. Okay, but nowadays in the pediatric hospitals, the MRI very beautiful. The environment is very beautiful. Like the children's abroad, so they have to take a tour inside. Okay, how the MRI looks like, and so that they don't get it is a virtual reality. These things, but we can hear the parents directly can come inside the theater, and they can do the monitoring. They can be inside the MRI and be comfortable with the child, so that so we have two monitors, one inside which can be seen from the outside, and the outside monitor. Okay, this I can escape because this also I can escape sometimes. So it is a precarious balance. Both you have to avoid awareness as well as apnea. So it is a double-edged sword for all of us when you are using patients who are very far away from us. They are not with us. Okay, so it becomes quite difficult to maintain that. So procedures can be minor, but anesthesia is always a major, specifically in the MRI. Okay. So non-sedated other diagnostic tools are there. So are they possible? Obviously yes, with the pacifier feeding and the use of the value blanket, and the use of the incubator box. This this quite a comfortable. Sometimes you can do CT or the MRI in a small children. You need not give anesthesia. So that becomes quite. So contradiction, obviously all these metals, they are already ferromagnetic abnets. This I will escape because all of us, we know what things like implanted biological pumps, they are not. I think we usually make a list of it, those things are, just put it outside the MRI. If you are having these things, please do not enter. Okay. Well, these things are, I think we have to avoid, because the child is inside the small group. Everybody has to take care of, when the child is inside a small child. Such disaster occurs. It's quite terrible. Okay. So it's dangerous. Cath lab, I think one of the most comfortable to work place in a NORA is a cath lab. because people, those who are with the anesthesia technicians, they are very well versed with everything, whatever they are well equipped, So cath lab is, but they do also have a very highly invasive procedures like a cardiac cath and interventional vascular procedures, segments. Usually we do these cases with either with a ETT or LMA. Neuroradiological procedures, we do all these coiling aneurysms, but the only thing, once mainly they are under general anesthesia with the intubation and proper monitoring of all EtCO2 and everything. Okay, so this is like just a giving a OT in the cath lab, but they are only, we have to see to it that the connections are fitted properly. Okay, because when they are moving the table from here to there, there are the chances of disconnection, and you have to see that properly your vascular accesses, you have to give the extensions, and long tubings are provided, and your intubation. Okay, if the prone position, see to it that you are properly fix the tube. So because of the moving of the table, the accidental extubation does not occur. Well, in the the indications, but say in the procedure, the deliberate hypotension and the deliberate hypercapnia is usually is required. So it is a requirement of the rapid transition between the deep sedation analgesia and the awake responsive. So conventional GA anesthesia is much better for all these neuroradiological procedures. Radiation safety, all of they have a somatic effect and the genetic injuries. So I think that the maximum permissible radiation dose should be the 50 millisieverts, or it's a milli-SV annually. So it is a cumulative dose of 10 milli. I think we have to think about it, and the dosimeter or whatever they use, and all the precautions of exposure by wearing this appropriate lead gowns and all these things has to be done. The open communication between the radiology and the anesthesia team is very essential to minimize the radiation exposure. So adequate warning of the initiation in the radiology allows the anesthesia personnel to go out. I think all these things have to be taken care of. Contrast, yes, I have talking about, because in the pediatric patient, everything is a weight based. Okay, because just 10 ml, or in adult you give a 20 ml. Children, it is per kg, and the adverse reactions, you have the reactions you can have. Some of the predisposing factors, those who are having a patient with the renal disturbance, anxiety, or the medications on the beta blocker, they can predispose contrast media problem. What do you do? Prompt recognition of the symptomatic treatment. Oxygen bronchodilator, steroids are the standard treatment is there. Well, this is another, dreaded suit where I personally think that, maximum problems occurs because of the GI bleed, dysphagia, and the upper abdominal. All these are red flags, because the upper GI scopy and the lower GI scopy is okay. This is quite a invasive procedure, and we requires a very deep anesthesia. And these patients they're not normal patients. They have already, bled so much, anemic patient. They are unable to eat. They are cachexia. Their bleeding disorders are there. Okay. And with the invasive procedures, you require a relax, because if you cannot keep them very light, because it has so happened many times that the patients are quite light, and they put the, esophagus scopes, and you have a puncture or rupture of this, so in a very small child. So you have to see to it that these patients are quite relaxed in these endoscopic procedures. Upper GI, lower GI, and the hepatic problems are there, and patients for any these things come, like in a pylori obstruction. If they want to see any obstruction, this is like becomes a hormuz, like all the vessels are not going, so it is very important wherever the obstruction is there, this thing is there. Anesthesia concerns are quite a GI bleed. The patients internally, these patients you cannot send them home, because if they keep bleeding inside, they can just collapse. So these patients have to be admitted. They have a reflex. Duration of the procedure sometimes quite prolonged. So you give a prolonged anesthesia. Aspiration risk. Recent aspirations are quite, and sometimes the bowel preparation for the colonoscopy is not done. So the quite disaster. Second times you have to see to this. So actually in a GI suit, there is no one right way to anesthetize the child for the endoscopy, but there are plenty of the ways to mess it up. Okay, I won't say, okay, in a GI endoscopy, this is a one particular. Everybody has, their own way of, but we have to see to it that, the when you are and the scope is introduced, the child is really quiet. Otherwise, it can injure esophagus. Intubation is the probably best plan if you are in any doubt about the patient or the procedure or even the endoscopy. So usually we have a TIVA for the short procedure and a complete general anesthesia with the intubation. We have for these things. So here, 1 minute, we have a very nice video showing about the liver biopsy. Here we get a lot of liver biopsy patients in our institute, and we usually do under a mask. This is our quite typical of Vadia, this thing, because we just tie the mask and your hands are free, eyes are taped, and you just give one local anesthesia, and it can be done rather than giving all the, because the child is really very cachexic, does not require much of anesthesia for the these things. Okay, I think we'll go ahead and see to it that the back movements are there, your hands are free. Okay, and you can just give a local and just get away with this. So this becomes quite a comfortable. Now, forget the, you don't have to forget about the gas problem. This is the biggest problem in the GI tract, because intra and the post procedure gas in the stomach can causes a lot of issues like a discomfort, pain, nausea, aspiration, splinting. So most of the time when they are doing the colonoscopy, the child desaturates if you are putting only on the TIVA, because the stomach is distended and sometimes can go into the arrest. So when the lower GI scopy, when it is taking a longer time and when they are just pushing air and air and air, I think you have to put the tube, it is better, and you have to tell them, okay, now you stop. Airway, your air pressure, when post-operatively and putting the nasogastric, you can put the post, because post-operatively child will keep crying because of discomfort and the pain. That's quite an important thing. Now new development is there. I think this one is the LMA gastro. Through this you just put a LMA through this endoscope can be put, but this is available for the adolescent. Still, it is not yet available for the small child, but it's a really very good one for adolescent. I personally have used it, and it's quite a good one. Well, you have a guidelines and you have to follow them, because you require anesthesia when endoscopic procedures require prolonged sedation. You require a more anesthesiologist. Bronchoscopy, I will not talk into detail because it's a chapter itself. Maybe you can come. We get a lot of both the diagnostic and the therapeutic bronchoscopies. Like this child is there post-procedural vocal cord issues were there. So this is, we wanted to say the airway, and we just induced with just a propofol. We don't give much things, and here we usually give a local anesthesiologist. You can see the sound, the cracking. We give this, give us some local anesthesia and do the scopy. But only thing, we do not feed them, because even immediately after the giving the scopy, because local anesthetic is been given and they can just aspirate. So that okay, so this is a very beautiful, this is a bronchoscopic, this thing, how I do it, we have made, because actually it is thanks to ISA people, central, because ISA people had told us, IAPA people, all those who are doing the pediatric cases, various procedures, how you do it. So this is, I won't run this video because video is very good, but longer time. I'll post this video, and this is available on the ISA ISA website. This is how I do it, and we have done this for the pediatric diagnostic bronchoscopies. How you do it in a various ways. I think because of the time constraint, I will not run this because this is quite a huge video. Okay. Okay. Now, obviously, foreign body also causes a lot of problems. General condition of the patient, NPO status is preoperative preparation, avoid narcotics in hypoxic child, oxygenation is important. Anesthesia, you can give either with the TIVA or general anesthesia with the side arm ventilation, the way we have given it here, and the monitoring of the oxygen and ET CO2 is quite important. Intra and the post-procedure complications are quite high. Nebulization and the IV lignocaine to reduce the irritation of the instrumentation is must for the repeat check scopy if required if the foreign body is not yet completely out. Okay. Now, a last part I will talk about is the dental chair. I think many of us, we do dental chair, and what is the problem is the dental chairs are not straight. Okay, that is why we sometimes we get, worried about the how suppose if something happens to the child, there is no, you can do head low and you cannot, make a, CPR. So when you are putting the child in the dental chair, 2, 3 things you have to think about is in case if the problem is there, you have to have one flat surface. Okay, where you can take the child in case of mishap, you can take the child outside and do the CPR. That is a must. Second thing is in a dental chair, you don't do, complex surgeries. This is like, complete roller rehab. Usually we don't do, usually do in a surgery. But small tooth extraction, pulpec, capping, or some taking the impressions, which it takes a 5 to 10 minutes. Definitely you can do in a dental chair with a general anesthesia or TIVA or even with the inhalation. So here, I do a lot of these dental cases, and these cases are done under, inhalational agents. Usually we use their inhalational agents, like they have this nasal CPAP type of mass endoscopy. You give just as they give a local anesthesia and the small doses of, some propofol or dexmedetomidine, and then the child becomes quite a comfortable child. So it is like a daycare procedures, and the child you can go home comfortably. Well, when if something goes wrong in the radiological suit, what, I think we should not, wait till this happens. This room safety, all these things should be maintained. Like you use the protocols, you know the procedures, experience level of the staff team, familiarity with the process, and standard equipments, regular schedule, and less prone to the forensic preparations is quite important. Well, complications of the NORA, they are not less. Lots of complications are there, and there are dreaded complications up to lightly stridor. These are the commonest one, up to the cardiac arrest. Anything can happen, and you have to be ready with these complications. Management of the emergency is what immediately stop the procedure, activate the code blue system, whatever the systems you have. Those who are in the private practitioner, I think they should think over, okay, suppose in case of the problem, how they are going to tackle it, whom they are going to call. Is there any nearby hospital where somebody can come to their help? If the surgical emergency occurs, invasive procedure, call for a help of the senior surgical colleagues, transfer to HDU or SIU, give proper, documentation, right documentation, and give them the proper over. Okay, talk to parents and the relative. That's a very important thing. Okay, so you have some of these guidelines, like each location's source, whatever the soap is there, monitoring good standards, adequate illumination, sufficient space. Obviously, we don't think that sufficient space is sometimes is necessary. Trained anesthesiology staff and adequate trained staff to support the anesthesiologists is very important. I think we always we see to it that our staff, who are there in the MRI suite or CT or endoscopy, they are well versed with the ATLS or SELS. Okay, so regularly they undergo training. Okay, so even the mama, those who are helping us, to the sisters themselves, they do these courses because it is mandatory now. Post anesthesia recovery is very important. Okay, usually the children are kept outside. That is not done till they are recovered. That somebody has to monitor them. Well, like OR checklist is there, NORA checklist also should be there. I think each what you have checked it, where just sending the child home at home, that is also should be there. Okay, so develop a work culture is very important rather than talking that okay, NORA is quite difficult. So you can make the things easier, for the things. It is easier for us also. Think, plan, and communicate, and everybody understand that nobody wants any mishap anywhere. Okay. The conclusion is children who are less than 2 years are at a very great risk. Okay, especially neonates. So some basic standards of monitoring, same, not some actually, it is the same basic standards of monitoring in an operating room has to be there. Availability of the skilled staff with the understanding, established protocol and guidelines, teamwork between clinicians, radiologists, physicians, radiology technicians and the nurses is quite important, and nothing less than the good communication with each other. I think at the end, this baby's day out is quite should be happy, and we also the people also those who are caring for the babies also should be happy. Thank you very much.
Thank you so much, ma'am, for your wonderful insight trying to simplify pediatric NORA. I'm sure it would encourage even the occasional pediatric anesthetist to start conducting cases in NORA. So both our esteemed speakers have re-emphasized that we need to follow our standard operating procedures. We need to anticipate preoperative problems and issues, do a thorough checklist. And as per all our regulatory bodies, international, national, we have to insist on equipment and monitoring as we do in a traditional OR with trained personnel, so that definitely in future our NORA procedures would be a cakewalk. So thank you so much, both our esteemed speakers. So, ma'am, we have a few questions in the. Do we have time to take the question? Alvina, Malik?
Questions.
Yeah, we have 2 or 3
Maybe.
questions actually in the chat
Yeah.
box. Dr. Chaya has asked, do we need anesthesia machine in an MRI compatible set? I mean, MRI compatible machine in an MRI setup? And can we do sedation without anesthesia machine and monitor? I think only one of you could take this.
Daftari ma'am.
Swati, you want to answer?
So if your setup where you are going for MRI is a well-oiled machine as doing really well, I think you should make them understand that having an anesthesia machine which is MRI compatible is a good investment. And that way they can advertise also. And it is going to be for patient safety. It's not for your comfort levels that you will be most of the time doing TIVA, or rarely in pediatric patient, you might be doing inhalational induction. But otherwise, to have a MRI compatible machine is a very good idea. Most of the hospitals would have, but it becomes difficult for freelancing people where they go to the centers. And I think if the center is doing well, they should ask for it. Because I've seen a regular pulse oximeter, if you put, sometimes patients tend to get burns. Because you may feel that just at least let me have pulse oximeter or something. Even monitoring has to be there. So I would personally feel that it's a good investment if the center is doing very well. And somebody's asked which machine is MRI compatible. So at our hospital, we have Datex Omeda, but earlier I have seen even a dragger machine. I am not aware of any Indian company making a MRI compatible machine. I'm not sure. There must be. So actually that dragger was Usha dragger at that time. And that was a MRI compatible machine.
MRI Siemens machines. They both are having MRI compatible machines. I think if they have good volume of cases and the anesthesiologist, if they think that the patients are of a very small child, less than 5 years, if the scan is having a problem, I think they can definitely say no, because it is for their safety, not to, and patient safety also.
Correct.
See, this always a logistic occurs when they say how the anesthesiologist can say no, but anesthesiologist can say definitely no. Even in our centers also, if our centers is quite well equipped, we do have a MRI compatible machines and all. So suppose if something is like the patient has come fasting, means fasting, that patient cannot be taken. So whatever the safety rules are there, you need to follow that.
Yeah, because
we have done, these MRI cases. I tell you, I have done all these MRI cases when the machines were not done. I told you just now, I have kept a machine, anesthesia machine just outside the MRI suite in case in the child. And I have taken this oxygen cannulation, very long cannulation from outside machine to the patient end. That also I have done. Okay. So
absolutely.
through inside. But I think in this current era, when it is better to put your foot down.
Yeah, because
Let the
9 times
radiologist.
of 10, you may not have a difficulty. But the day
Yeah.
difficulty happens, the parents or the relatives are not going to spare you. Why didn't you tell us that you didn't have this? We would not have come here. So it's always medical legally, it's best to have it for patient safety and your own safety. That you can do justice to what you are doing.
There's another question, ma'am. Is it necessary to have a defibrillator ready for NORA? Yes, quite an
Yeah,
obvious.
so if you are working in a cath lab,
Yes.
you will have a defibrillator on, right? So it depends on what venue you are working and what type of cases you are doing. So depending on that.
No. See, Roshana, see what I'm saying. Wherever the patients are being done, okay, under local anesthesia or even under general anesthesia, most of the wherever we in my this thing setup where even the normal simple ophthalmic setup is there where you don't require much, but still defibrillator is an investment. It is a dead investment, but you have to have it.
Yeah, the day you will use it, it will become 100% profitable investment.
No, we should not use it, but I think
No,
it
you
is
will
a
have
mandatory.
to. Yeah.
Mandatory it is.
And it's mandated by the ASA guidelines also. 2023 amendment
Yes.
for NORA. It is a must.
Yes, it is a must.
Defibrillator with
No, it will be asked. See, if something happens, did you have a defibrillator there? Because you cannot call a defibrillator from somewhere else in a peripheral hospitals. Okay. So not forget about the peripheral hospital in our this thing major huge hospitals where anesthesia department is somewhere or OT is somewhere else, the remote places somewhere else is there. If that patients require a defibrillator, to bring to defibrillator to that remote place is also a task, even if you have.
So there's besides this, there's one more question about ECT in psychiatry ward, which is done away from main OT complex. So how do we go about it? Dr. Suraj Yadav.
It is very funny. As early as 1981, not 81, 83, when I was a resident in anesthesia, we were doing ECTs in a psychiatry ward at KM Hospital. And even in those days, we used to have one huge cylinder, flow meter, ambu bag, valve, and mask. We used to have a laryngoscope with one adult female and one adult male sized tubes with us. And we used to even have atropine and other resuscitative drugs. So we had done it then with pentothal. We have done it with pentothal and scoline at that time. I'm sure with propofol, the recovery is going to be much faster. So you can always do it.
Ma'am,
and that is how it is, NORA.
We continued the same tradition, what you're saying. So they just used it so many. So 97, 98
No, but that's for see in those days only pentothal was used for ECT, and we used to go to the the psychiatry ward. Okay, there used to be some psychiatry ward is also remote area place. This was like a NORA only somewhere
Ward 19, madam.
So but then everything we had there, like we had a ambu bag, we had a laryngoscope, we had a appropriate sizes tubes. Those cart used to be there. That cart we would move along with each bed.
Yes, and at least at that time it used to be only clinical monitoring. Now maybe you can have one multi-parametric monitor where you tie up a BP cuff, have a ECG, and have pulse oximeter. And
At least pulse ox in ECT.
yeah, I think
Pulse
you
ox is
can
must.
very safely and scientifically do an ECT in psychiatry ward.
Sadhana
Madam
ma'am,
Chobatka's hand-on pulse, definitely yes. I think that skill is been lost. This
Yes.
skill of hand-on pulse is lost in a current these things. I think all the teachers have to take efforts to keep them
Even hand ventilation.
tell students that keep a hand-on pulse.
Even hand ventilation.
To see that that also gives a lot of, because we never had pulse oximeter in our PG days. We always operated cases without pulse oximeter. So sometimes we always tell our student that even under the tree also we can anesthetize the patients, because we clinically we monitor the patient. We don't require, because your eyes are trained, your senses are trained that way. Okay, we don't rely on monitors. So we have to currently there's all these things.
It's a very small infant needing MRI. Can we manage without sedation if we wrap them, make them, feed them?
Yes,
and
sucrose, yes, glucose, yes. Glucose. Sometimes what happens in our hospitals also in Madhya, we do this neonatal these things. Child is being neonates is been fed, okay, by mother, and then the child sleeps. So we wrap them properly, and then we keep a monitors so that they keep a oxygen venti mask, and we. But sometimes what happens during MRI, immediately in between the child wakes up. That can happen, but most of the time this can be done. So if the child wakes up, then we have to do under anesthesia. So then we have to wait that the child becomes at least a 3 hours fasting, and then you take them. So that is logistic is, so it becomes a very haywire. If you have a list of 15 MRI, and if this happens in between, and then suddenly when emergency patient comes, so there a starvation, that's what I emphasized on starvation. Now this child, if the moves in between, he's already full stomach. Okay, so that time of MRI is wasted. So sometimes they do give, but the neonatologists, they do give pedicloral, but we don't like that pedicloral. As an anesthesiologist and our department, we don't use pedicloral at all. And then so many times it had happened that child, outside was given a pedicloral, and the outside MRI, not because the child is uncooperative, then they are shifted here. Okay, but the child is still under the effect of pedicloral. So then we are giving the midazolam. Okay, no problem. You give a midazolam, you give a propofol, but see to it that the child is, awake. You give some IV fluid, because for a prolonged time the child is being, fasted.
What do you use, ma'am, commonly for MRI in pediatrics? What drugs you use?
We do use a ketamine. We do use a dexmedetomidine.
IV.
So in a neuro cases, yes, in a neuro cases, we do use infusions, because we have these pumps. We do use a propofol, and we do use a CO also. We do use a LMAs. Depends on how you are doing a case, how the child's clinical situation, or say positioning. Difficult airway, definitely we intubate these patients or put a LMA. Lateral positions, LMA. If normal airway is there, slightly bigger children, I think smaller the child, airway has to be secured for MRI. Smaller the child. Bigger the child, you can manage with all this TIVA.
No, there's one interesting question
See, that's what I'm saying. See, these cases, like in an endoscopy, the dose of ketamine and the propofol will be different than the dose of in an MRI, because that's not this. You just want to make the child sleep. Okay, you don't want to anesthetize the child. Where in GI scopy you have to anesthetize the child in
there is a
such
nice
level that the
question.
child is relaxed. So everywhere the dosage is very different.
Yes,
One
ma'am.
Dr. Avinash Bhosle is asking, should we start cases in private diagnostic center where most of the centers, radiologists are not present, even if all things are available? I think he only should be answering this.
President, ma'am.
Because tomorrow,
President, Dr. Avinash Bhosle. Avinash Bhosle. Welcome, sir.
Avinash, I don't think. I think they have to be there. If
start the case.
if it's coming to the hospital, you can start the case, but don't say that I am at a home and then later on I will come. No, that way it doesn't work. They have to be there in the this thing, because see
There is
what
online
happens if they
reporting,
are
madam.
not present. Avinash, see, when you have done a MRI, and if that the scan is not correct, the child has to undergo again. Okay, if the radiologist says, okay, this scan is not correct, even we have to rescan that. So that's not allowed. That you should not allow. Only you be present, you see the scan yourself, because you are submitting, subjecting child another for the invasive, or say whatever the procedures, again anesthesia. So it is not allowed. Even even if you and not child is, or patient, adult patient is not anesthetized,
Correct.
why the patient has to undergo again, just because the radiologist is not there? That's not done.
So
It is a waste
same.
of
I want
resource.
to give that message only. So I have asked this question.
Okay.
No. I think we have to be firm in some cases. Like this is like the surgeon is somewhere else. He is taking a flight from another city and he is telling, okay, you start the case. I am there. See, sometimes the flight gets cancelled. Okay, what do you do that? Then you just cancel, extubate the child and go away. No, let that surgeon be in the campus.
Okay.
Then there
Okay. Thank you,
is,
ma'am. Thank you.
yeah.
Thank you.
Then there is one more, Dr. Varsha Vora is writing specific anesthesia consent for CT and MRI. I don't understand this. Is this a comment or a question? Yeah, if you're going to be even give monitored anesthesia care or mild sedation, there has to be a consent by the patient. And of course, the
No, this is a procedural
escalation
consent.
matrix also have to be informed to the patient that if it becomes difficult or patient becomes non-cooperative, we may have to add something.
Ma'am, there's also a question on
No. During consent only, what type of anesthesia you are giving? Okay, usually we explain to the patient what type of anesthesia we give. Okay, like not in adult. I'm talking about in a pediatric patient. So we make the parents understand what you are going to do. Okay, in case if there is a prolongation, this can happen specifically in an endoscopy, because in the endoscopy can happen anything. Okay, after the inside the scope is there, that child can be get admitted, get an ICU because of the severe bleeding. So these things are to be told to the this can happen. Not necessarily it will happen, but this can happen. So can be ready. Suppose if they want to, they have taken the consent for the upper GI scopy, but now they are not finding anything and they want to do JR. So you cannot repose the child, but then you need to take a consent for lower GI scopy. Now an upper GI scopy. So I think by taking the consent, the hepatologist or GI endoscopy, they should take a consent in such a way that suppose in case if you are not finding anything, we may go further. That also they have to think, tell.
Ma'am, any comment on
Then
intranasal
intranasal dextrose. Dr. Naresh Paliwal sir पूछ रहे हैं intranasal dextrose. Yeah, it is quite good. That very nice combination is there, dextrose. I mean, personally I like it, but I think I like it. Patients who are undergoing for the surgery. For small surgeries. You can just give the caudal or herniatomy. It's very nice, but for NORA patients, dextrose becomes a quite sometimes. The recovery is slightly delayed. We don't want that the patients are sleeping all the time. So in a patient, we want, this is like a daycare surgery. We want them out, and after beyond 6 o'clock nobody should be there in the MRI, because beyond 6 o'clock even the most of the staff is not there. So beyond the 6 o'clock, even the sisters, there are very few people there. Nobody is there to monitor the patient. So we have to see to it that the patients are awake. So, but this is a very good combination, but not for NORA. Definitely not. Or if you are giving, then monitor the patient.
Ma'am, I have one question regarding discharge. So is there, because none of the guidelines mention any particular time of discharge. So any comment on that? Or is it like minimum 2 hours, or till the baby is fully awake, or even in an adult? So many a times they come on OPD basis and they want to get discharged also the same day. So any mandate regarding the number of hours that this patient should be in or be in the hospital before he is discharged. So is it only based on the scoring system, like the ALDES score, or in pediatrics, the other scores what we have in peds? So is it only on that, or is it the some number of hours that they should be spending in the hospital after the procedure and after they're fixed out?
So as I said, if a muscle relaxant has been used and reversal agent has been used, then at least for 2 hours after reversal agent. But otherwise, if you have done it on inhalational agent or TIVA, what you see is how is the child or an adult behaving, may be able to sit up on his own, or if he wants to go to the washroom, how much help does he require, is asking for water, or all these things would help you. And like I've seen radiation therapy kids, the minute they are awake, we do them on, because what happens if you do them on TIVA, there's a lot of expenditure encountered, in the sense because they have either a PIC line, smart line, or have a port. So to access that, you have to have a chemotherapy nurse. And if they have undergone multiple procedures, the peripheral lines are not available. Initially, what we used to do was we used to take a peripheral line on a Monday, pack it up till Friday, and use it for 5 turns. And then Saturday, Sunday, so that the child is more comfortable without this thing, we used to take it out. The next Monday, we'll put a new one. But now there are certain patients who've undergone surgery and chemotherapy from peripheral line and all. Usually their veins are very difficult. So if you are doing it on inhalational agent, they are up and about very fast.
Okay.
So what we do is, once they start crying and ask for something, we give them Glucon-D or something, and then they are out in 1 hour. I suppose they also become fast metabolizer after repeated exposure to anesthesia.
One more thing we have not talked about, like neurodevelopmental anesthetic effect, especially for the small children. I'm not talked about because it is not a. So when we are a small child, I think shorter the better. Okay, the anesthesia exposure, neonates and all. We don't wish them, to undergo for a long scan. So we have to see to it that the scans are very faster, and because although it is not yet proved that neurodevelopmentally this anesthesia, this OPOP process is there, but still I feel the anesthetic duration should be shortened, in a small child.
So I think
we'll conclude now. Yeah, because our tech support the time is getting. So we'll conclude the session. Thank you so much, ma'am, Daftari ma'am, and Prajna Sawant. It was very good session.
A very, very fruitful
Very
and
good.
excellent
Yeah.
evening. And now I hand over to Anjana to propose the vote of.
Thank you. Thank you. There were excellent and very insightful lectures by both our speakers and excellent moderation. I thank both our speakers, Dr. Swati Daftari and Dr. Pradna Sawant, madam, in describing these both scenarios in adult and pediatric patients. I thank Dr. Rochna Bakshi for excellent moderation and all our delegates for their questions, for their active participation. We may not have been able to answer some questions which I can still see in the chat, but due to lack of time, I hope that we will be able to answer them sometime in the future. I would like to thank our president, Dr. Olvina, and all our managing committee members for their contribution, and the Jenica Technology for the tech support, our SAMS President, Dr. Avinash Khosle, and Dr. Sheetal Dalal, Secretary, for their support, and National Dr. Professor Praveen Malhotra for his presence and words. Thank you very much. And with this, I bring this session to a conclusion. Hope we meet again soon with newer topics. Thank you very much.
Thank you,
Thank
Anjana.
you.
Thank you.
Thank
Thank
you,
you, ma'am.
all of you.
Thank you
so
all.
much.
Thank you. Thank you very much.
Thank you all.
Thank you, everybody. Thank you.
Thank you. Good night.
Thank you. Long live ISA.
Long live ISA.
Long live ISA.